four drug combinations are being studied, and they definitely will form part of the treatment schema in myeloma. The studies that were done in Europe doesn't really were positive studies with the quadruplet for both transplant eligible patients and non-transplant eligible patients. However, those regimens are not regimens that we use for induction here, so we don't use thalidomide or melphalan. But the Griffin data that we just discussed show deeper responses, and more than likely that is going to result in approval of that regimen, and daratumumab more than likely will become part of the induction therapy. In myeloma over the years we've had triplets and like lenalidomide, bortezomib, and dexamethasone that induce very good responses. If you look at the published data for this regimen, the reported response rate is 100%. However, what daratumumab adds is an increased number of deep responses, like complete remission, stringent complete remission, and minimal residual disease negativity. Since we have learned that all those are surrogates for better progression-free survival and overall survival, this is likely to be approved again, and it's likely to become part of our induction therapy. If this patient had high-risk myeloma, probably you could have selected the same induction regimen. We don't have data yet on how the bortezomib, lenalidomide, and dexamethasone impacts the high-risk population from the Griffin study. Probably that data is going to be upcoming. However, if you look, for example, at the Cassiopeia study that compare again BTD versus BTD-DARA, the group of patients that got BTD-DARA had a better rate of response and had also better progression-free survival. So when you look at complete remission, which was the primary endpoint of the study, patients with high-risk myeloma did not seem to benefit as well as the patients with standard risk myeloma. However, in terms of progression-free survival, when you do the subset analysis, there was benefit. So these patients, again, remain a challenge, but regimens that can actually get a better rate of complete remission are even more important in this patient population. For patients that are transplant ineligible, right now we know that the best regimen available would be lenalidomide, dexamethasone, and daratumumab, and that is based on the MAIA study that show better progression-free survival, better rate of complete remissions, and better MRD negativity. Daratumumab is a treatment that is very well tolerated, so you could easily administer this drug for patients that are more frail or they're older. The main issues with daratumumab would be increased risk of infection, so you have to follow these patients very carefully. But I would say that at this point, even when you're seeing a patient that is non-transplant eligible, you do have to consider a triplet as opposed to a doublet. And my first choice of treatment, again based on the MAIA study, would be the combination of Revlimid, dexamethasone, and daratumumab. Once DBRD gets approved, it may or may not impact what we do in reference to transplant. It's a really unanswered question because the data that is looking at this regimen as induction includes transplant as part of the regimen. We do know that as you keep treating the patients, right, they get induction, followed by consolidation by transplant, followed by more intensification, and then maintenance. The responses keep getting better. So it's really not just the induction that matters, but all the treatment that we give these patients. The question would be, what if you have a patient that you give this induction, that you continue to give this treatment, right? Not just 4 cycles, but continue treatment until you get the deepest response. We know that these regimens, while the response, the time to response, median time to response is only 1 month, the best response, for example, for regimens like daratumumab, lenalidomide, dex, you don't see it until 1 year. So you really would have to keep treating these patients to see really the impact of only the quadruplet in contrast with transplant. So I think we would need a study comparing these two to really define if we can stop doing the transplants, right, and just continue these patients on the quadruplet therapy. The other question in this setting would be if the goal of therapy in myeloma nowadays should be to get that patient in complete remission and possibly in MRD negativity. So the other question would be, what would you do with a patient that you give the triplet and that patient achieves that goal before transplant? And whether transplant is really necessary in that setting, or getting there to stringent complete remission or MRD negativity by whatever method, right, is enough.